Hi everyone, today I'll be talking about lateral ankle sprain. Lateral ankle sprain is one of the most common soft tissue injuries and account about 40% of sporting injuries. There are two types of lateral ankle sprain, high ankle sprain or low ankle sprain. At the lateral ankle, there are many structures. There are ligament complex, bony structures and also tendon structures. The ligament complex, there are syndesmosis joint, ATFL or anterior talofibular ligament, PTFL or posterior talofibular ligament, CFL or calcaneal fibular ligament, and lateral talocalcaneal ligament. For the bony structures at the lateral ankle, there are calcaneus, talus, lateral malleolus, cuboid, and fifth metatarsal bone. There are also peroneus longus and peroneus brevis tendon at the lateral ankle. There are multiple risk factors that can contribute to lateral ankle sprain. It can be divided into patient-related or environmental-related. For patient-related, patient who have a limited dorsiflexion, patient who have a problem with balancing or proprioception might have a high probability to get the lateral ankle sprain. Patient who have a previous ankle sprain also have high probability to get another sprain. Besides that, patient who have greater height and weight and patient who have a larger foot size will also have a high probability to get a lateral ankle sprain. For environmental related risk factor that can cause lateral ankle sprain, the indoor court sports, uneven surface, slippery surface also can contribute to the lateral ankle sprain. The mechanism of injury, usually inversion type of ankle injury. If inversion with foot on plantar flexion, usually ATFL will be injured, and if there's an inversion injury with dorsiflexion, usually CFL will be injured. There are a few other associated conditions or injuries related to lateral ankle sprain. We can divide into bony structures, ligament or tendon structures, and also chondral injury. For bony injuries, there might be base of fifth metatarsal fracture, a lateral malleolus fracture, and also talus fracture as well. For ligament or tendon injuries, deltoid ligament and also peroneal tendon also can be injured when patient have a lateral ankle sprain, and also chondral injury. Usually patient with lateral ankle sprain presented with pain over the lateral side of the ankle. There might be swelling or ecchymosis. Patient might have difficulty to ambulate or unable to weight bear. Patient who have chronic ankle sprain might have recurrent instability. On examination, on inspection, there might be swelling or ecchymosis. Patient might have antalgic gait or unable to weight bear. RM might be limited due to pain or swelling. On palpation, there might be tenderness over the course of the ligament, over the ATFL, CFL, and also over the syndesmosis. For the special test, we can do anterior drawer test to test for ATFL. We look for excessive translation of the talus over the tibia. Usually, grade 1, there is 3 to 5 millimeter translation. Grade 2, 6 to 9 millimeter translation, and grade 3, more than 10 millimeter translation. We can also do a Talatit test to test for CFL. We look for excessive inversion, more than 15 degrees compared to the contralateral side. And we also can do squeeze test for high ankle sprain. The lateral ankle sprain can be classified into 3 categories. Grade 1, there's a no ligament tear. Grade 2, ligament stretch but with no tear. Grade 3, there is a complete tear of the ligament. For the imaging, in acute injuries, the decision for imaging in ETD can be decided based on the Ottawa ankle rules. In Ottawa ankle rules, the ankle X-ray series is only indicated if there is a tenderness over the malleolar zone, and any of these findings. There is a bony tenderness up to 6 cm proximal to from the tip of lateral malleolus, or there is a bony tenderness up to 6 cm from the tip of medial malleolus, or inability to bear immediately or at the ED. The foot X-ray series only required if there is a bony tenderness at the midfoot zone with any of this finding, bony tenderness at the base of fifth metatarsal, or bony tenderness at the navicular bone, or inability to bear immediately or at the ETD. The standard view for ankle X-ray would be epilateral and mortise view. From the X-ray as well, we can measure few things if we suspect high ankle injury. We can usually in syndesmosis injury or high ankle sprain, there might be reduced tibiofibular overlap, usually less than 6 mm on AP and less than 1 mm on mortise view. There might be also increased medial clear space, more than 4 mm on AP view, and also increase in tibiofibular clear space, more than 6 mm on AP and lateral view. AP and mortise view. For the ankle X-ray series, we can do AP lateral and oblique view. MRI usually indicated when patient have persistent pain 6 to 8 weeks following the acute ankle sprain. In MRI, we can it is useful to look for the ligament injury, osteochondral injury, or any other ligament injury. Okay. For the treatment of lateral ankle sprain, it can be divided into conservative or operative management. For conservative management in acute setting, we can apply a price principle, a protection, rest, ice compression, and also elevation of the limb. And immobilization might be required for a short period of time, for approximately 1 week. To immobilize with boot cast or A cast, and then but the functional rehabilitation should be started immediately. Started with motion exercise and progress with the muscle strengthening and also balancing or proprioception exercises. For chronic lateral ankle sprain, we're focusing on the strengthening the muscle, and also we can use ankle support to reduce the recurrent instability. For operative management of the lateral ankle sprain, it can be either anatomic reconstruction or tendon transfer with tenodesis or arthroscopy. For anatomic reconstruction or tendon transfer, it is indicated when patient have grade 1 to 3 injury with pain or instability despite conservative management, or it is also indicated when patient have grade 1 to 3 injury with bony avulsion. For arthroscopy, it is indicated when patient have recurrent sprain and chronic pain due to impingement lesion. Thank you.